I'll talk about SMILE, but we're going to talk about the future of refractive surgery and kind of what's up and coming, but mostly focused on SMILE. So, there's a myopia probably crisis across the globe. By 2050, half the world's population is going to be myopic. And most of the people think that this is probably an issue just in the United States, in Asia or not over here. But by 2050, about 60% of the US population is going to be myopic as well. So what does that mean for people who do refractive surgery? That means hopefully business is booming. And refractive surgery is expected to grow. It kind of reached its peak in the mid 2000s, early 2000s. Started to fall, and then kind of after COVID started to go up again. So the procedures that we have right now for refractive surgery are very, very, very good. LASIK and PRK are kind of our mainstays and what we use. They both use kind of an excimer platform. We can correct myopia, hyperopia, and astigmatism now. Large studies show they're probably equivalent. And then long-term results are pretty identical for most people. I mean, the procedure's been around for almost 30 years now, and there's more than 50 million procedures across the world that provide great results. So something had to come, and it had to beat it. And it's really hard to do when you have such good results with with PRK and LASIK. So SMILE started probably in the 2010s. Started instead of small incisional lenticular extraction is actually large incisional extraction, lenticular extraction. And what it does, it uses a femtosecond laser instead of an excimer laser, and it creates a lenticular that can be removed through a small little incision. FDA approved only for myopia correction in 2016, but eliminates the need for a flap, eliminates probably lower risk for a dry eye, better corneal biodynamics, and then the main thing that Zeiss will tell you is there's one platform. You only have to buy this laser. It's a VisiMax laser that currently in the United States is the only one approved for SMILE. And you use one platform where the patient sits under, it completes the lenticular creation, and then you remove it. So and the VisiMax is very good. The VisiMax has a standard flap thickness of 4.4 microns. Patients think that, or Zeiss will tell you that the patients have better comfort, has the lowest rise of any intraocular pressure rise. So with the intralace laser, with the Femtech laser, as you can see over here, intraocular pressure rises goes up to 150 to 200. But with the VisiMax laser, the intraocular pressure rise only goes up to about 50 or 60. The FDA approvals from about -1 to -10. There's no FDA approval for hyperopia at this time. There's studies going on for that. And astigmatism up to -3 diopters. So that covers a large amount of people that walk into your clinic, about 80% of the population that walks in. How it works, basically there's a side cut that's performed. That's that one in red. And then the interface, the lenticular interface is a straight line, and then the cap interface and the small little incision that's created. So there's a quick video. It's a pretty fast procedure. So the first cut you'll see here is the docking. And then after that, there's the lenticular cut that will first occur. Then the side cut will occur. And then the cap cut will occur. And then right down over here, there's a little side cut right here where the incision is made. So right after you dock it, this is sped up about 4x, but it takes about a minute to do. After that, it's at that same platform, same procedure. This is again, you tunnel through that incision, use this kind of like scallop tool to tunnel above and below the lenticular. So that's below, and then it's above. And then use a small little tool and just pull it out. And then SMILE is done. That's the entire procedure, and it works really well. In terms of intraoperative and postoperative considerations, there's always, because of that lower rise of intraocular pressure, there's a concern for suction loss, decentered ablation. Epi ingrowth is not as bad as compared to LASIK. There's a smaller incision. There's either 2 millimeter or 4 millimeter incision you can use. Interface haze, and then the real problem with SMILE is you can have these lenticular adhesions or remnants. So here's an example right here of a piece that was left over and that had to be removed later. Advantages of SMILE, no plaque creation, preserve the anterior stromal integrity. There's been studies that show has higher surgical corneal tensile strengths, reduced risk of possible ectasia, faster nerve regeneration. Than the regression rate is really well over time. Compared to LASIK, there's the big thing with SMILE versus LASIK. It does provide better dry eye symptoms, better corneal sensation. This is a study published in JCRS about 2 years ago. In the first 6 months, dry eye does fall in terms of corneal sensation, but they do recover at the endpoint of 12 months with LASIK versus probably around 6 months with SMILE. But this is theorized to be due to the corneal nerve plexus. It's theorized that the LASIK flap is more anterior and it causes more disruption of the nerve plexus rather than the SMILE. Is kind of, you don't have that disruption of that nerve plexus causing less dry eye in patients with SMILE. Again, for SMILE to work, it has to compete with LASIK and PRK, which are excellent. So the first two bars are the blue bars. Those show visual outcomes at 6 months and 12 months for patients with SMILE compared to a lot of studies that showed LASIK and PRK. And as you can see, LASIK and PRK do really well. At 6 months, 98 to 100%, 97 to 100% at 12 months of having 20/40 vision or better. And then compared to SMILE, it has to really compete with that. And it does, but it has to compete with something that's already very, very good. In terms of visual target, it has a very good visual target. I mean, what you attempt to remove and what you attempt to get is very good. The mean kind of deviation with SMILE is minus 0.02 diopters from what you aim for. And then about 99% of eyes are within a diopter of what you predict. The kind of hallmark of refractive surgery is you have to have visual stability. And SMILE has shown that it has very good long-term visual stability. Less than 2% of people lose a line after 12 months. However, kind of what the big problem with SMILE is that it hasn't been expanded to hyperopes. Mixed astigmatism is an issue. LASIK patients often kind of experience vision quality much better, much faster, while SMILE takes a couple of weeks to kind of get there. There's wavefront guided technologies and LASIK that haven't come through in SMILE yet. If you do SMILE a lot, you do have to have the platforms to have LASIK and PRK in your same office. If you have an undercorrection or overcorrection to make enhancements, there is a larger learning curve with SMILE compared to LASIK or PRK, but kind of probably the biggest one is cost. I mean, the cost of the VisiMax laser and the platform is probably in the millions of dollars. So if you're a refractive surgeon somewhere and you're already doing high volume LASIK and PRK, the need or the want to go to SMILE is not that high because your current methods are providing great results. So what's in the future? What's after SMILE? This is called CLEAR. There's all these names, but this is corneal lenticular extraction for advanced refractive correction. It's built on the SMILE platform. However, it can potentially treat hyperopia, it can treat presbyopia, it can treat irregular astigmatism, and it has an adjustable kind of lenticular thickness. So imagine someone with keratoconus has a steeper inferior cornea. You can customize the lenticular based on different areas in the cornea to provide a better result for the patient. Undergoing clinical trials in Europe and in Asia, nothing here in the United States. And the real thing about this is you may be able to link CLEAR with corneal cross-linking to provide a long-term refractive and keratoconic risk in patients with keratoconus. Something else is called FLAT. This is femtosecond lenticular allograft transplantation. And what this does is a femtosecond laser makes a little pocket where you can add tissue. And that's been used to prove that you can treat hyperopia and presbyopia. The tissue integrates. There's no synthetic implants. You can adjust the lenticular thickness and shape. Something kind of like this is already happening with CTAC, which is a new kind of up-and-coming keratoconus treatment. Again, undergoing clinical trials in Europe and Asia. Presbyon is a special laser blended vision platform that uses the LASIK platform, and it kind of provides a kind of multifocal corneal platform that helps a person see far and near and provides that extended depth of focus. It's actually approved in Europe, used widely in Germany, UK, and Asia. Hasn't gone over to the United States yet, but it's something that's used quite a bit over there. Trans-PRK is something that's kind of up and coming. It's basically PRK, and people sell it as like a no-touch refractive surgery. So traditionally in PRK, the surgeon has to manually remove the epithelium. In this kind of new platform that they'll make you pay a lot of money for, you don't remove the epithelium, the laser removes the epithelium, and then does the laser reshaping, you put a contact lens, and then you're done. A few studies might show that it has lower risk of corneal haze as compared to traditional PRK. This is approved in the United States. However, I don't think many people are doing it. We all know about the EVO ICL. It's approved in the United States. It corrects myopia up to -20 diopters. However, this is kind of the next generation of what the ICL may be, and it's an extended depth of focus lens. It's not FDA approved in the United States. However, studies are ongoing, available currently in Europe and Asia, but it provides kind of a extended depth of focus. A patient may be able to see kind of far, near, and up close. And it may provide like alternative to someone who probably is too young to get clear lens exchange, but already has reached that presbyopic age. And then lastly, which is probably the very, very future, it's called LIRIC, laser-induced refractive index change. And this is still theoretical and still in kind of experimental phase, but there's no laser. There's no tissue that's removed. The cornea isn't modified. There's nothing added. And basically, and I don't know exactly how it works, but it changes the refractive kind of index of the cornea. And that's all it is. And that helps you able to see better. Experimental phase, but I mean, the benefits may be no corneal haze, no flap, no dry eye symptoms, and it's a one and done procedure. So in conclusion, refractive surgeries are kind of expanding beyond LASIK and PRK. It's very hard to expand beyond something that's already very good and you get very good results. But we want to look at things that may be able to preserve cornea, preserve tissue, lower the ectasia risk, dry eye symptoms. And I think AI and kind of these new biotechnology platforms will really help correct the vision in the future. Cool questions.